Good evening, everybody. As Valerie said, I'm Matt Fakhoury. I am a board-certified urologist who specializes in men's health and sexual dysfunction in the Westchester County area and Queens, New York. And we're really excited to get this going tonight. I know personally that the team over at Boston Scientific has worked extremely hard to make this happen for all of us, and I can't wait to move forward. And I'm happy to answer any questions that you guys may have, or girls. And I look forward to sharing all this information with you, and I hope you all learn something. All right, so we're going to jump into learning about erectile dysfunction, how it happens, why it happens, when it typically happens, when it presents, how it presents, and ways that we can fix it and prevent it from happening. So, just a brief outline of what erectile dysfunction is. It's defined as the persistent inability to achieve or maintain an erection firm enough to perform sexual intercourse. Now, the numbers that you see at the bottom of the screen, how common is it? I really do believe that these numbers are probably much higher in reality. It's just such a sensitive topic that men and their partners have a difficult time talking to their physicians about it. So, 1 in 5 men over the age of 20 suffer from some kind of erectile dysfunction. And it's estimated that more than 50% of men over the age of 40 have some degree of erectile dysfunction. And again, I do think these numbers are probably underreported for obvious reasons. It's just such a sensitive topic that many male patients don't even want to talk to their partners about it, and hence they end up avoiding the act of being intimate as a result of that. So we're here to shed some light on it, just let you know that you're not alone and that we have ways that we can prevent this from happening and correct it. Slide. So, the erection process. Two parts to the erection. Number one is getting it, and number two is keeping it. And a lot of times we have our patients, our male patients who come into our office, and they're able to obtain the erection, but it's difficult to keep it hard. So with arousal, the nerves of the penis become activated, muscle relax, which allows blood flow leaving the heart to get into the corporal bodies, which are the two tubes that you see at the bottom of your screen. They kind of look like the ant eyes. Those are the two tubes that are responsible for keep getting the erection, getting the blood flow into the penis, and those are coming from the arteries. And there's a second part to this, which is the harder part, pun intended. That's where the veins are responsible for allowing the blood in the penis to remain in the penis. And that's what really is responsible for maintaining and keeping the erection. As it says at the bottom of the screen, the erection is compressing the vein so the blood can't escape from the penis, enabling the penis to remain intact. When that does not happen, this is the most common reason why men have erectile dysfunction over the age of 40. It's because of something called venous insufficiency. Slide. So, some of the other causes associated with erectile dysfunction. And just to kind of generalize this, the whatever is good for your heart is good for your penis. And whatever is bad for your heart is essentially bad for your penis and bad for your erections. There's no single cause of erectile dysfunction. It's usually a culmination of different factors. And unfortunately, a snowball effect sort of happens along with this journey. So there's both physical and psychological reasons for erectile dysfunction. Some of the risk factors, like I said, things that are bad for your heart are bad for your penis and bad for your erections. As we grow older, smoking, diabetes, high blood pressure, uh, dyslipidemia or high cholesterol, depression, obesity, and a sedentary lifestyle. Over on the right hand of your screen, you'll see common conditions associated with erectile dysfunction, as we said, the vascular part, which is really how the blood flow is getting to the penis, staying within the penis, and whether or not it actually escapes. And that's what we just touched on a little bit earlier as far as the venous leak or venous insufficiency. 30% related to diabetes. We're going to get a little more into detail about that. Medication. A lot of the medications that your primary care physician or your cardiologist are going to recommend that you take in order to make sure your blood pressure is maintained, make sure your cholesterol is maintained. Even as far as antidepressants, anti-anxiety medications, these medications unfortunately do sometimes come with a cost of causing your erections not to work the way that we want them to. So it's kind of like a chicken or egg thing at that point. But again, the most common way to help fix the erectile dysfunction is maintaining whatever is good for your heart is good for your penis. Pelvic surgeries or trauma is another sort of aspect that we touch on. Slide is fine. Thank you. Now, this is the reason why I feel like a lot of the numbers regarding erectile dysfunction are underreported because of the psychological and psychosocial impact that it has on men and their partners. Okay. Men who experience erectile dysfunction may experience anxiety, depression, low self-esteem, self-confidence, and a decrease in overall quality of life. Men with erectile dysfunction tend to be emotionally distant and withdrawn from their partners for obvious reasons. And this is probably one of the most difficult aspects for a patient to overcome and finally develop enough confidence to come into the office and be open and honest about what they're experiencing about regarding their penile dysfunction. Slide. So, the gist of what we're here for today is the penile implant and how it can be a tool in our toolbox in order to help fix this problem. What we're talking about on this slide specifically is the satisfaction rate amongst patients who've had a penile implant in place. There's about a 90 to 95% satisfaction rate in patients who have received a penile implant. Specifically, the AMS 700 which is an inflatable penile implant, and we'll talk a little bit more about how it works, how it's placed, and the recovery period shortly. In a survey of 80 patients who received the AMS 700 penile implant, 97% of patients would recommend the implant to a friend. I never hear, once patients have a penile implant, I never hear them say, I wish I didn't do this. The most common thing that comes up, the most common theme that comes up with patients who've gotten an implant is, I wish I did this sooner. And I'll talk a little bit about why they say that. Slide. So we touched on the diabetes portion of things of how it could be a risk factor for erectile dysfunction. We're going to jump into a little more detail here. Erectile dysfunction and diabetes. Half of men with diabetes have sexual dysfunction. Okay. And this can be a direct result of the blood sugars just not being controlled. How does this happen? To take something really complex and kind of break it down into more simple terms, the nerves that are responsible for delivering an erection just are no longer sensitive to the stimulus that your brain wants to send down saying it's time for arousal. And that is a direct response of the blood sugars within the patient that are just not controlled and causing the nerves of the penis to just become sort of lazy and just not responding the way that we need them to. Beyond that, even in patients that we start on oral therapies, and we'll talk a little bit more about that, we try to give them these medications as step one after behavioral and dietary changes, of course, but they may not respond well just because at some point the nerves just can't do it anymore, and we need the nerves intact in order for the erection to occur. Slide. So, how can erectile dysfunction actually come from diabetes? We touched on this a little bit. It's really about the nerves damaged by high blood sugars, and they're no longer being responsive to the stimulus that your brain is sending down that you want a healthy erection to occur. Slide. Factors that may increase erectile dysfunction in men with diabetes, obviously advancing age, how long they've had the diabetes, whether or not the glycemic control, something that you probably heard your primary care physicians bring up, the hemoglobin A1C, which is that average of what your sugars are over the last 3 months. If that number is in that 8 to 9 to 10 range, it's going to be very difficult for you to naturally achieve an erection. And on top of that, even with the medications, you may still have some difficulty trying to get the erection, but even harder, again, no pun intended, is keeping that erection. Slide. Erectile dysfunction and heart disease. This is a really important portion of this talk. So, one of the first things I said when we started this webinar was anything that's good for your heart is good for your penis, and the opposite is also true. Anything that's bad for the heart is bad for the penis. Symptoms of heart disease may develop within 2 to 3 years of living with erectile dysfunction. Erectile dysfunction is a risk factor for future heart-related or cardiac events. The severity of erectile dysfunction is related to the severity of the actual heart disease. This is a really important point. Erectile dysfunction precedes coronary artery disease in almost 70% of cases and can be used as an early warning sign of future heart disease or even a future heart attack. Believe it or not, there are some studies that actually show that we can diagnose a pending heart attack 2 to 3 years before it actually occurs with a test called a penile Doppler ultrasound, which essentially allows us to understand how well blood is leaving the heart and getting to the penis. Next slide. So I mentioned a few things about arteries. One of the smallest arteries in the male body is actually located in the penile. in the penis. The penile artery is only about 1 to 2 millimeters. Your urologist may talk to you about a penile Doppler ultrasound study, which is basically where we're allowed to the opportunity to check blood flow and velocities going to the penis and what is escaping out. If you look towards the right of the screen, what you'll see is the main arteries that are supplying blood to the heart are nearly double the size of what is inside the male penis. As a result of that, the first arteries and first vessels that are actually affected by heart disease or coronary artery disease are the ones that are located within the penis because the diameter is so small. So anything as far as causing damage to the heart, the first thing it's likely going to cause is damage to the penis itself. Slide. Reducing risk. I beat this already to the ground. Anything good for the heart is good for the penis. Improving heart health through healthy lifestyle choices may lower the risk of erectile dysfunction. Eating well, physical activity, exercising, losing weight, stopping smoking, limiting alcohol, and obviously illegal drugs, and ways to reduce stress. Now, just to talk a little bit more about this, specifically speaking about our male patients that come and visit us for erectile dysfunction, the first conversation I usually have with them is tell me about how much you exercise. Are you able to walk up and down a flight of steps? Can you walk around the block? Can you pick your grandkids up? These are really important questions. And sometimes the patients look at me and say, Doc, I'm here for you to make my penis hard. Why are you talking to me about these other things? Because they are absolutely necessary to gauge. In order to make sure that it's possible for us to help you with this erectile dysfunction, we need to know how well you're taking care of yourself overall. Slide. Okay, erectile dysfunction and low testosterone. So, what we talk to our patients about whenever they come in with the complaint of possibly having low testosterone because their primary care doctor may have told them your testosterone levels were really low, it's probably why you have erectile dysfunction, go see your urologist. Testosterone is the building block of obtaining an erection. It allows the patient to achieve the desire or libido, which a lot of you may have heard. The libido is responsible for the desire to have the erection, not necessarily responsible for delivering the erection. Okay. But in order to have a healthy erection, we want to have a healthy testosterone because, like I said, it is the building block. So low testosterone is more likely to affect people who are older. Obesity is a major point. Okay. Patients who come into the office who are unfortunately obese, heavyweight, especially in the midsection area. The midsection area is the most common place where testosterone actually gets converted over to estrogen, which is the female hormone. And obviously, guys who want to achieve healthy erections, they may have higher levels of estrogen strictly related to the amount of weight gain that they have in the midline section. Poorly managed diabetes, obstructive sleep apnea, chronic medical conditions such as kidney function, cirrhosis of the liver, or HIV or AIDS. Slide. Low testosterone. Symptoms include, but are not limited to, overall decreased sex drive. The feeling and the desire to have a healthy erection is just not there anymore. So it's almost impossible to achieve a normal erection if the desire is not there. And again, one of the most important aspects of getting a healthy natural erection is the response of the nerves. The nerves are just going to be asleep if the testosterone, the hormone responsible for that arousal, is low. Erectile dysfunction, loss of armpit and pubic hair, shrinking testicles, hot flashes, low sperm count, depression, increased body fat, as we discuss, gynecomastia or enlarged breast tissue, muscle strength is lower, and decrease in endurance. Slide. Okay, so we'll go through this pretty quickly. How can we treat low testosterone in men? There's actually quite a few options out there right now. Number one, although not listed here, um, is making sure you're getting to the gym, whether it's cardio, whether it's weight exercises, joining a class of some sort for exercising. You have to be able to make sure that you're staying in shape to the best of your ability. Outside of behavioral dietary modifications and exercising, we talk about testosterone replacement therapy or TRT. That includes injections into the muscle, patches, there are oral medications, tablets by mouth, skin gel, and nasal gels that are available, and also pellets, which also is not listed here, but we can also place pellets that last up to 6 months in patients where it's no work on their part. It's a 2-minute procedure in our office, and you can talk to your urologist about that. Slide. This is a big one. Erectile dysfunction and prostate cancer treatment. So, how are these two things linked? Why does it matter? We're talking about erections and the penis. Now we're talking about prostate cancer treatment. So, prostate cancer, as you know, is one of the most common diseases that affects the male population. There are certain ways that we can fix prostate cancer and eradicate it from one's body, including surgery and radiation. Both of those things do cause erectile dysfunction. However, surgery itself has a much higher risk of developing long-term erectile dysfunction. So, what we'll sometimes hear other urologists speak about and patients bring up in our office is, well, I got nerve sparing done when I had my robotic prostatectomy. Why do I have erectile dysfunction? And with all due respect to the urological oncologists, our colleagues out there, it's very, very difficult to tell a patient that they're not going to have erectile dysfunction after a prostate cancer surgery. It's almost impossible. So what I tell patients is who are diagnosed with prostate cancer and they choose the option of undergoing a radical prostatectomy, that whatever your erections are right now, post procedurally, they're not going to be the same. Okay. And that has a lot to do with the nerves. We talk about nerve sparing, but unfortunately, we're still not at a level where we know exactly what nerves, when doing a prostatectomy, control the control the erection during a prostate cancer surgery. Slide. So essentially, what we're doing here, this is a really good picture in a patient diagnosed with prostate cancer that is undergoing removal or resection of the prostate cancer via a robotic surgery or an open surgery. The prostate gland and the surrounding organs, such as the seminal vesicles, are completely removed. And what we're doing is reattaching the bladder to the urethra, which is a tube that carries urine outside the male body. So once the bladder is reattached to the urethra, you're going to unfortunately develop urinary incontinence is one thing, but a big thing is also the erectile dysfunction, which all urologists talk to their patients about after undergoing a radical prostatectomy. Slide. So, treatment options. Sexual dysfunction after prostate cancer treatment. There is hope for nearly every man living with erectile dysfunction. I could not agree more with that statement. 25 to 75% of men who have a nerve-sparing radical prostatectomy to treat prostate cancer experience erectile dysfunction afterwards. Also, penile shortening. That's also a big thing that we talk about with patients as a risk factor after a radical prostatectomy is done. Now, this is what I touched on a little bit earlier. Even with a nerve-sparing robotic surgery, erectile dysfunction can persist to a year or more after the surgery. And in order to manage expectations for our patients diagnosed with this disease, we have to be honest with them and tell them that whatever your erections are right now, you have to expect that they're not going to be as good as they were after the prostate cancer surgery. Slide. Okay, erectile dysfunction and Peyronie's disease. Slide. So I'm sure a lot of patients have seen the commercials on television with the bent carrot. This is Peyronie's disease. Peyronie's disease is essentially a situation where a male comes into our office because of some kind of curvature to the penis. It usually develops after micro trauma. That's what we're thinking, at least. The theory behind developing scar tissue in the penis has come from is scar tissue or plaque buildup in the penis. And this can lead to a curved or bent penis, especially during an erection, making it much more difficult to penetrate. Obviously, there's cosmetic issues with that as well, and sometimes it can cause pain for the partner or pain for the patient during intercourse. Now, a lot of times, erectile dysfunction and Peyronie's disease do present together, and what we'll talk about a little bit later is how we can fix both of these problems in the same setting. Slide. Peyronie's disease treatment options. There are several different options out there. Sometimes this does not have to be treated. It really depends on the quality of life, the quality of intercourse, and whether or not it's causing discomfort for the patient or their partner. What we talk about is oral medications. We talk about injection therapy. But more often, what we're bringing up to patients is surgical intervention because we want this to be an issue that is completely solved after the surgical intervention. One of the things that we talk about in patients with Peyronie's disease, we always ask them, are you capable of achieving an erection on your own? A lot of times the answer is no. And in the setting of erectile dysfunction, not being able to achieve an erection. And when that erection is actually achieved, there's curvature in the penis that's causing discomfort or some level of pain for the patient or their partner. We talk about a penile implant because the penile implant is one of the procedures that we can, actually the only procedure that we can offer where we can solve both for the erectile dysfunction in a more permanent fashion, as well as solving the issue of the erectile dysfunction resulting in Peyronie's disease. Slide. What should men know about erectile dysfunction and Peyronie's disease regarding the penile implant surgery? The penile implant may be an option for men who are struggling with erectile dysfunction and simultaneously have Peyronie's disease. During the procedure, in order to address the Peyronie's disease, a penile implant can be inserted in order to correct that curvature, sort of like that, so that the penis, upon achieving an erection, is straight and no longer causes pain or discomfort for the patient or their partner. Slide. Who can treat erectile dysfunction? Okay, so one of the first physicians that a patient may speak to about erectile dysfunction is their general practitioner or their internist, which is part of our backbone. We rely on our colleagues in internal medicine and family practice in order to make sure that these patients are getting to the right urologist who treats these things. Uh, Besides the general practitioner, we have a urologist who specializes and focuses on the penile anatomy, the penile physiology, how we can fix these things in a safe manner. More specifically, there are urologists out there who are especially trained in prosthetic surgery. Prosthetic surgery involves the placement of penile implants or artificial urinary sphincters, and it does require a certain amount of training in order to do these procedures comfortably and in order to achieve a really good outcome for the patient and their partner. Slide. Okay, so this is probably why we're all here tonight. Erectile dysfunction treatment options. We talked a lot about the lifestyle modifications. We talked a lot about behavioral therapy, dietary modifications. What's good for the heart is good for the penis. But sometimes patients do all of those things and they still cannot achieve an erection that is satisfying to whether it's to the partner or to the patient themselves. We talk about oral medications, the Viagra's, the Cialis's. We talk about vacuum erection devices. All right, this is an option where you can buy a vacuum erection device. Your urologist will talk to you about which ones they recommend because it's really important to make sure that there's one with a pressure gauge on there. The vacuum erection device, kind of like what it sounds, will sort of suck blood into the penis for as long as you can possibly tolerate it. And that'll allow for a decent erection. However, it does not allow for the patient to maintain that erection long enough, usually, in order to achieve a sustainable erection for intercourse. And a lot of times patients do complain of bruising and pain. So obviously that's the last thing someone wants to do prior to having an intimate moment. Injection therapy. This is effective, but talking to a patient about sticking a needle in their penis is not very fun. But patients unfortunately do get into the habit of looking for other options outside of the ones that you see here. And we tend to talk to them a little bit more about penile implants when they're ready for injections, because at the end of the day, there are studies that show that injection therapy, it's called trimix, injection therapy is associated with a high risk of developing plaque formation or Peyronie's disease. And obviously, that's the last thing that we want to cause for a patient who wants to achieve a healthy erection. And last but not least, the penile implant, which we're going to talk a little bit more in detail shortly. Slide. Lifestyle changes, mental health support. We talked a little bit about this as well. We want to make sure we're maintaining an active and healthy lifestyle. A lot of times we'll have patients who come in who are in the younger generation and they'll complain of erectile dysfunction. And one of the things that we talk about is the effect of psychogenic erectile dysfunction on one's erection. And I tell my patients all the time, if the big head and the little head aren't on the same page, it's going to be very difficult for you to achieve a healthy erection that you're satisfied with. So we want to make sure that when we go into an intimate moment, that it's a calm environment. And I tell my patients, calm, cool, sexy is the way to go. You want to take the pressure off your penis because your penis does not want to feel like it's on a stage and ready to perform. Okay, that is opposite of what we want in order to achieve a healthy erection. health and lifestyle modifications, quitting smoking, losing excess weight, increasing physical activity. That'll help us regain some sexual function or prevent it from worsening. But again, we have patients who do all of those things and still aren't able to achieve the erection that they are satisfied with. Psychotherapy is pertaining to the psychogenic or mental component of erectile dysfunction. And what we want to do is help decrease the anxiety associated with erectile dysfunction because it's so difficult to go into an intimate moment and the patient is worried, is this going to happen again? Am I going to go through this again? This is so embarrassing. I'm ashamed. We want to take all of those moments of pressure away from the penis because it's much better at performing at its own pace without the pressure of the patient. Slide. So some of the medications we talk about, what their goal is try to get more blood, prioritize leaving the heart back to the penis. Side effects. None of these medications are side effect free. Headaches, congestion, upset stomach, nausea, muscle aches, facial flushing. In patients who are taking other medications related to heart disease or coronary artery disease, again, this is kind of that chicken or egg thing. What we worry about is patients who take nitrates or alpha blockers. Taking a supplement such as a Viagra or Cialis may drop their blood pressure significantly. So we always talk to patients about what other medications they're on prior to prescribing any of these PD-5 inhibitors. In a study of 20,000 men with erectile dysfunction, men with diabetes were twice as likely to move on to other treatments such as a penile implant in order to correct this erectile dysfunction without the need of having to worry, when should I take my medication? Has it been an hour before I had dinner? Dinner, unfortunately, food in the stomach is going to cause a change in the absorption of the medication. So it's kind of difficult for patients to time it appropriately and time it correctly. Slide. We talked a little bit about the vacuum erection device. A lot of patients that come into the office after being recommended a vacuum erectile dysfunction device by their urologist or their primary care doctor come back with bruising, discomfort, pain, and eventually they get to the point where they're just saying, this is too much work for me to have an intimate mode with my partner, and I no longer want to do this, and it completely shuts them down. So I don't push for the vacuum erection device too hard, but it is an option. Slide. Intracavernosal injection therapy. These are the injections that we talked about a little bit earlier, where we teach the patient and train them about how to inject a medication, usually called Trimix, which contains three different modalities in order to keep blood inside of the penis and maintain that erection. One of the scariest things about this medication is that it can cause a prolonged erection or a priapism. And unfortunately, that is one of the few urologic emergencies that we have that does require an emergency visit. Slide. The penile implant, in my eyes, the gold standard of erectile dysfunction. Okay, this is a permanent solution to erectile dysfunction. Okay, this is the only way that we can achieve the stopping of penile atrophy because unfortunately that thing that you may have heard in the past, if you don't use it you lose it, is true. Your penis will shrink over time if it's not getting the blood supply it once had, and it's kind of like taking care of a plant. If your plant is not getting that water and that sun, it's going to atrophy and shrivel up. And unfortunately, a lot of men will come in saying, this started about 5 years ago and my penis is just getting shorter and shorter, doc. How do I stop this? The only way to really stop this is with a penile implant. Okay, so a penile implant is a device that's implanted by your urologist into the penis that is intended to allow a man to have an erection by controlling it. It's a mechanical solution to a mechanical problem. The device is entirely contained in the body. No one is able to see it, and it is controlled by the user or their partner to achieve an erection. This treatment is designed to allow spontaneity. It gives the patient back that spark of saying, hey, I'm in the mood and I'm ready to go, and no longer concerned about when I take the medication, when should I inject myself, did I leave the medication in the fridge, did I forget to do the vacuum device, and the erection is maintained for as long as the man desires. Most common side effects or complications that we talk about are postoperative genital pain or infection, mechanical failure, and erosion. In a survey of 80 patients who received, again, that AMS 700, 97% of patients would recommend it to a friend. Again, I never hear a patient say, I wish I didn't do this. It's always, I wish I did this sooner. Slide. So, several different types of penile implants that Boston Scientific has for us. Number one is the AMS 700, probably the most common one that is placed. It's a three-piece penile implant that is inflatable, and we'll show you guys a little video about how it actually works. The AMS 700 Tenaccio pump, different kind of pump that's placed in the scrotum. And for patients with difficulty maintaining a grip, because the two implants, which are inflatable over on the left-hand side of the screen, require some kind of dexterity, meaning your fingers have to be strong enough to be able to pump the scrotal pump. The Taxtra, on the other hand, is a malleable penile implant, which doesn't require the patient to manipulate a scrotal pump. Slide. So the AMS 700 penile implant, inflatable three-piece penile implant, has three design options, the most variations of any penile implant in the United States, and it's also available with inhibizone, which any surgeon typically would love to have in their operating room because it's decreasing the risk of potential infections, and that is what we fear the most with this surgery. But if you listen to your urologist, the chances of having an infection are quite low. Inhibizone is clinically proven to reduce revision surgery due to infection. It's designed closely to mimic a natural erection, provides rigidity when it's inflated, and a natural flaccid appearance when deflated. That is a huge point that for patients that come in who are very well read and well versed about the different kinds of implants that are out on the market, one of the things that we hear most commonly about the Boston Scientific AMS 700 is when it is not inflated and flaccid, it is the most natural appearing penis out on the market right now. Penile implants have been in use, clinical use for over 50 years, uh, and there's over 500,000 Boston Scientific penile implants sold a year. Slide. So this is a short video basically showing us how we can manipulate the scrotal pump in order to achieve an erection. And again, this entire device is located in the body, so you could be at the gym, in the shower, and nobody knows you have this in place unless you let them know. So essentially what we're doing is we're pumping the scrotal pump. It could take up to 6 or 7 or 8 times in order to achieve a full erection, and you can maintain that erection for as long as you like. One of the important things that we should mention is once obtaining the erection, you are still able to ejaculate as long as you haven't had a radical prostatectomy. Okay, you are still able to maintain ejaculation and, more importantly, maintain sensation. So it's not like the patient gets this surgery done and they have an erection, but they're not enjoying it. No, they have full capability of climaxing and enjoying the part that we all yearn for during intercourse. The penile implant, what to expect from the procedure. It's done in an outpatient basis. Typically, you'll come into the hospital and you'll go home the same day. Depending on the type of penile implant, an incision and your urologist preference, an incision may be made close to the penis, within the scrotum, or above the pubic bone. Often the surgeon uses one incision to allow everything to be instilled inside of that one incision. The procedure is performed under anesthesia. Usually it takes about a few days to return to a regular routine light activity, but we tell our patients you're going to walk out of the hospital essentially, but it may take a few days for you to get back to your normal routine. So at the last line, we talk about urologists typically instruct men to wait 4 to 6 weeks before using the implant. A lot of times we can have our patients start using the implant as soon as 3 weeks. We have me specifically, I have patients come in the day after the surgery to make sure everything went well. You'll have a small drain that is removed. And I like to see my patients once a week for 3 weeks. Each step of that journey, we're basically teaching the patient how to manipulate the pump, utilize the pump, and we hopefully have patients within 3 weeks able to have intercourse. Slide. Cost and coverage. Commercial insurers may cover the diagnosis and medically necessary treatment of the erectile dysfunction. Medicare has a national policy for erectile dysfunction, which includes penile implants, but it also depends on where the patient may live. You do have to work with your doctor's office and ensure your insurance carrier to check for coverage prior to receiving the treatment. And there is financial assistance programs available that I know Boston Scientific also has in place in order to help with the expenses associated with the procedure. Slide. So, what are the benefits of the AMS 700 Boston three-piece penile implant? 97% satisfaction rate. We know that patients will Thank you. Typically, it's covered by insurance, and this is a huge portion of the discussion that I have with patients is how long it lasts. And there are some studies that show that it can last up to 15 or 20 years. So it's not like this is a yearly event. Every 5 years, this does not have to be changed out. It's inside of you. Your body accepts it, and you're able to use it for the course of over 10 to 15 or 20 years. Slide. Risks. What we talk about with our patients is device malfunction, mechanical failure, which may require the parts of the penile implant to be replaced or the entire device to be replaced. We talk about possible migration. We talk about infection, unintended inflation of the device, pain and soreness, swelling afterwards. Slide. You are not alone. So this is a very difficult topic. Obviously, it's easier for me to talk about it because I talk about it consistently, literally on an everyday basis. But for each patient that comes into our office, we're very, very sensitive towards the fact that it took a lot of guts and confidence in order for them to come in and talk to us about this very, very sensitive topic. This is a strain mentally, socially, emotionally, and especially a strain on one's partnership. Patients will come in and tell me that I just avoid any kind of intimate moment with my partner because I know where it's going to lead. And unfortunately, this, believe it or not, is a reason why patients sometimes get divorced because they're not able to perform the one that the way that they once were. And we're here to help. And that's all that we're doing. We're going to provide the information for you. Talk to your local urologist about how you can make sure that this is something that you can place in the past. You will make all of the necessary changes. We're confident in our patients once they have this discussion about the changes regarding diabetes control, weight loss, ensuring that your heart disease is under control, that you're taking the right medications. But again, even when all of those things are accomplished by the patient, we still may have to go a step further. And the penile implant shouldn't really be thought about as a last resort. It should be thought about as a tool that'll allow patients to regain the confidence that they once had and restore the intimacy back in their partnership and in their relationship.